Good evening, everyone. Thank you for joining us tonight for the Paediatric Emergencies presentation, part of Chris O'Brien Lifehouse CPD series. My name is Lydia. I am part of the CPD team at Central and Eastern Sydney PHN, and also working with us tonight, CPD Program Officer, my colleague Christina. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognize the continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. I also extend that respect to Aboriginal and Torres Strait Islander colleagues joining us tonight. Please be advised that this event is being recorded and will be available on our YouTube video library shortly. Tonight's session is accredited for 1.5 educational activity CPD hours and will be submitted on your behalf shortly after. If you have submitted any additional activities, it will be managed with RSCGP on your behalf. At the end of the webinar, evaluation survey will pop up on your screens. Please take the time to fill that out to allow us to issue your certificates of attendance and submit RSCGP. Remaining CPD events are available on our website. Please go there to view them and to register. Please note this is our last event in Chris O'Brien Lifehouse CPD series in 2024, and I would like to take this opportunity to thank the Inner West GP Education Advisory Committee for the work and representation of the CPD education that we've delivered in 2024. And I would like to thank personally to Dr. Claire Stewart, who is chairing our meeting tonight, Dr. Peter Piazza, Dr. Edmund Lee, Dr. Evelina Vincenzo, and Dr. Kenneth Tonk. On behalf of CPD at CESPN, we would like to thank you. And I would like to move on to our event tonight and once again introduce Dr. Claire Stewart, our member of advisory committee, and Claire will give us a short overview of health pathways. Thank you, Claire.
Thank you, Lydia. Thanks everyone for coming tonight. As Lydia said, I'm just before we start going to give you a very brief overview of the pediatric pathways and health pathways in general. So let me just, I've got some slides here. So it's just a few slides. Hopefully everyone knows about health pathways. There's 2 separate sites that cover the CESPN area, so one for Central Sydney, one for Southeastern Sydney. You choose which pathways you use based on where your patient will be accessing services, so not necessarily where you are located yourself. Sydney does RPA, Concord, Canterbury and Balmain, and Southeastern Sydney does Prince of Wales, St George, Sutherland, St Vincent's and the Sydney Children's Hospital. You can now use the same username and password to log into both Southeastern Sydney or Sydney Health Pathways. The username is connected and the password is healthcare for the time being. It's just a brief outline of some of the sort of emergency paediatric pathways that are on the Sydney Health Pathways site, including a new one called Urgent Assessment and Management Services, which includes information about pathways that are not ED-based emergency services available for children. Another brief outline of the Southeastern Sydney pathways. So they've also got some referral pathways for urgent paediatric assessment and admission and acute care in the community, including urgent care centres. So they are available there if you want any more information. Just a little bit of information about using health pathways. It's generally pretty self-explanatory once you're in. There is a search bar at the top that will bring up a number of different pages that might link to what you've searched for. And then if you click on the the page link, it'll take you to the page, and over on the far right, you can open a tab that will expand all of the drop boxes for you, and your search term will also be highlighted in the pathway. So if you're looking for something specific, it's pretty easy to find. You can also search for specific services. If you put them in quotation marks in the search bar, that should bring up where they feature on the site. And again, you can just expand all and find those pretty easily. You can use your health pathways use and log it as CPD, so that you can claim up to 12.5 hours annually, reading journals, including accessing websites which Health Pathways incorporates, and then you can also claim an additional 5 hours of reviewing performance if you use that material to then change your patient care. The easiest way to do that is to just record it using the quick log. I presume most people will be using the RACGP CPD Home, and so the quick log is really easy to use. And yeah, so you can get sort of 15-ish, 17.5 hours with your health pathways if you need it, if you want it. Just another thing, Health Pathways is rolling out personalized logins, which will start in December. This is sort of a way for you to personalize your experience with Health Pathways, and eventually it will also do the CPD tracking for you, so you can just submit it at the end of the year. So there's a few benefits, but just so everyone's aware that in the next sort of month or so, you are going to be prompted to set up an individual Health Pathways login. And then just some contact details for Southeastern Sydney and the Sydney team if you need anything. So I'll just stop sharing and go on, I guess. So we are going to talk about common paediatric emergency presentations to general practice, and we've got Dr. Lisa Lee Horn, who's doing the presentation tonight. Lisa is a FACEM who works as a VMO at Canterbury Hospital and is also the clinical director of the VCCC with New South Wales Ambulance. So I will hand over to you, Lisa.
Thank you, Claire, and thank you very much for the invitation to come and speak with you all tonight. I was just saying to Claire, I'm actually quite nervous, but we'll push through, and I'm sure it's, I'm very excited to speak to GPs tonight. I really value what family practice and community care does for us in the hospital and in ambulance. So I'm really looking forward to speaking to you all tonight. And I do encourage interaction. So please, if there's any questions throughout, I'm happy to be interrupted or write it into the chat, and Claire will interrupt me in due course. So I'm happy to answer questions through the talk. You don't have to wait till the end. So I will share my screen, and everyone can see my slides.
Yes, thank you.
Perfect, excellent. So I wanted to just tell you a little bit about my background, but also to demystify the service that I work for, just so you get a little bit of an understanding and a premise of where I'm coming from when I speak. So I'm a VMO at Canterbury ED. I did all my training at RPA, Canterbury and Bankstown. So my understanding in Sydney-based care is in the inner west and outer west. And I am also the clinical director of the Virtual Clinical Care Centre at New South Wales Ambulance. And just to give you a brief idea of what that service is we have three main functions. The most important function that we have is our secondary triage service. So when you first call 000, you'll get asked if you want police, fire or ambulance. If you request ambulance, you'll get put through to a call taker who's done a 6-week course in a piece of software called ProQA. They will ask you a series of questions, you'll be put through an algorithm, and then you'll get triaged. You'll either get triaged as someone who requires a an immediate response, and then everything below an immediate response, so deemed to be a subacute presentation, will then get pushed through to the VCCC and my call takers, which are, or call makers actually, are a mix of extended care and intensive care paramedics, RNs, and CNCs. They'll call the patient back and they will try and determine whether or not there's a better path of care than an emergency department. So they're looking at different referral pathways. They'll determine whether there's the person could potentially go in private transport or in a taxi. They will, or they may even up triage, because as you can imagine, there's many presentations that don't score very well on ProQA, because if you don't have chest pain or if you're unconscious or when you can't breathe, they're the three main things that get an immediate. And there's many other presentations that should potentially score an immediate response that lies outside of those three categories. So that's our secondary triage service. And that is really aimed at trying to deliver the right care to the right person in the right time and the right place. The other big role that we perform is we oversee all the interfacility transfers, so hospital to hospital, nursing home to hospital, etc. Because dispatch in an ambulance doesn't really have any clinical people in it anymore. So when you've got 5 different jobs that all sort of basically say the same thing, we provide the sort of clinical nuance to those jobs and help dispatch understand where the resources need to go and what time. So we'll contact the hospitals back and sort of try and determine who requires the most emergent resources. Because as you can imagine, the stats are that there's about 3,000 000 calls to ambulance a day, and there's only about 300 cars on the road at any one time in the state. So the game of maths doesn't really work. And then the final role that we play is we have a 24-hour emergency doctor on-call service for the clinical advice line. So when paramedics are with a patient and they have to either work off guideline or get permission to use drugs in a different way, or they've sort of reached the clinical ceiling of what they know to do, they call the clinical advice line, and that is answered by a CNC or a specialist paramedic here at VCCC. And if they can't answer the question or approve it, then they get escalated up to the FACEM or the anaesthetist or retrievalist on call. So that's what I do, and that's how ambulance is sort of trying to tackle the pressure on them at the moment. So today I wanted to speak to you about common pediatric medical presentations in general practice. I think I mean, you all specialists in your own right, of course. So I am trying to, I will be going through things quite methodically, understanding that you probably all know a lot of this, but I guess knowing exactly when we want to see them in emergency, or maybe some of the frustrations that we've seen in some of the referrals or lack of referrals with some children, but also take advantage of the fact that, I'm here, and if you want to know what happens to these sorts of presentations in ED, please interrupt me and ask. I always like to have the floor with another specialist and ask those nuanced questions that you sort of always want to ask when you don't have that specialist around. So, like I said, please interrupt. The topics that I was going to cover was just to go through the febrile child, work of breathing, gastro, my own little passion, which is don't forget the glucose, a brief sort of thing on surgical presentations, briefly touch on mental health as well, and then go through some useful resources, particularly because half of my world is virtual care. So I just wanted to sort of talk about the referral pathways that we have available now, particularly in the Inner West. So just to reiterate, it really, when we're assessing a children, the ones that we definitely want to see in ED are the ones that look seriously unwell, whether they're febrile or not. The ones that look seriously unwell or even moderately unwell, particularly if their parent doesn't have particularly good health literacy, or they're poorly supported, or they don't live near a facility, they're the ones that we want to see in ED. So the seriously unwell, like would be the pale, mottled, ashen child who's poorly responsive. They're appearing really unwell to the professional. But also if the parent is raising quite, sorry, I'm in front of my notes, or if the parent is quite concerned because there's been quite an alteration in the child's behaviour. The drowsy, floppy child who doesn't rouse when they're or isn't staying awake, particularly enough to feed or take in PO food or fluid. The child that has that weak, high-pitched or continuous cry, the child who's grunting. The numbers that I will always keep in my head in ED is 60 and 160. So the child who's resping at 60 or more, or whose heart rate is 160 or more, are the ones that get me off my chair pretty promptly. And the child who has that moderate to severe work of breathing, who has reduced skin turgor or has a bulging fontanelle. The moderately unwell child, slightly lesser of the seriously unwell, but they're the child that has they're altered according to the parent. They may not necessarily be altered to us, but they're altered to the parent, and they might have a moderate work of breathing. They do look a little bit dry. They're producing less than 4 wheeze in 24 hours. So the febrile child, fever is 38 degrees or more. We in ED do want to see all the kids aged under 28 at corrected age for a full septic workup. So please refer them in. There's no question there. For the child that is 28 days to 3 months, we're also happy to do a partial septic screen. So that being probably a urine, a monitor of their vitals over time. And a majority of them would get a full blood count and a CRP just to and basically but really just to be monitoring them to see what the trajectory of the child is. A child of more than 3 months, however, we can usually relax a little bit more, particularly if the parent is savvy, the child is vaccinated. So if the child has had a fever and they're well, no investigations typically need to happen, and really it's just symptomatic management. If there's been a previous UTI, though, or the child's less than 12 months of age and they have a fever for more than 24 hours, you could consider to do a UA if there's no other obvious focus of infection. But I think the thing that often frustrates us in ED is the person who has had a fever for less than 24 hours and has started on antibiotics straight off the bat with no obvious focus of infection, and also that there's been no investigations done prior, just because starting antibiotics does muddy the waters, particularly if we're taking a blood culture or a urine culture from the child or the person. As you know, most fevers don't routinely need an oral antibiotic. Most of them are a viral infection, unless there's obvious signs of a bacterial infection. And the studies do suggest that below 1% of febrile infants have bacteremia. So we have time to play with, I think, with adequate safety netting and with the parents so that they know when to when to get further review and help. So the ones that I would consider referring, well, the ones I'd absolutely refer are the ones that are the neonates, the brand new neonates, or the child that looks unwell, particularly if they have a non-blanching rash, if they've got a fever for 5 or more days. I think the caveat to that being unless they've swabbed positive to COVID or flu, but really any child who comes down on the 5th day of fever, we will typically start to at least consider or work up for Kawasaki. And if they have a swollen limb joint, or if they're non-weight bearing or not using an extremity. I just thought under the umbrella of fever that I'd just cover the febrile seizure. most parents panic terribly, and I completely understand why, when their child has a febrile seizure. So they've almost always scoop and run to the ED or call an ambulance. But I just thought I'd cover it in case. But this should only really occur between 6 months of age and 6 years of age. And as long as it's a simple febrile seizure, typically we don't do anything except for monitor the child in ED for a few hours and then discharge them home with safety netting. So the simple febrile seizures are a fever plus an absolute history of a generalized tonic-clonic seizure. The seizure has lasted less than 15 minutes, which I find extraordinary. I couldn't imagine watching my child fit for 15 minutes. But most of them will not last that long. That there's been complete recovery back to baseline within an hour. That it doesn't, and that there's only been one seizure per febrile illness as well. So the second seizure, we would definitely, in that same febrile illness, we would definitely admit, do some bloods, and observe. But like I said, if it's a simple febrile seizure, we typically won't do any investigations, particularly when there's an obvious focus of infection and that the child's returned to their baseline mental state. There's no role for EEG in these children. Potentially, if they're having multiple, they will get referred on. But even in the complex febrile seizures where the children have, they don't fit this particular criteria, there's something else different, maybe either the second seizure in the febrile illness, etc. Even then, there's a limited role for EEG in these children.
There's a couple of questions about fever stuff, if you wanted to do them now, Lisa.
Yeah, that's fine.
So the first one is about when you in ED consider blood cultures. When would you do blood cultures in a child who's presenting to ED? And so should we think about that as a reason to send a child, I guess?
So absolutely in the neonate in under 28 days. So the up to 28-day year old, we would that's a full septic workup. So that is a chest X-ray, FBC, EUC, CRP. Depending on the institution, it'd be a procalcitonin, lumbar puncture, and a urine. So they get the whole workup, and they will start on IV antibiotics until they've had reassuring investigations. So usually they'll be on antibiotics for the first 2 days that they're admitted, at least until all the investigations are back. If the child is over that age, so up to 3 months, we won't necessarily do a blood culture. If the child appears to be well and there's an obvious focus, so it looks like an urti, it smells like an urti because, the whole house has got it, etc., we may not do the blood culture. We may just sort of watch and wait. However, we would keep them observed for a period of time to see what the trajectory of the child is. And then if they continue to become unwell or they didn't have an obvious focus, then we would consider doing a blood culture. So I think the answer to the question really is the really little ones or the children that are at high risk, like the preemie kid, the failure to thrive kid, the parent who you're just not, you're not certain that they'd go for follow-up, they should all come in. But yeah, and then the decision to be made to do the blood culture at that point.
Thanks. And there's a couple of other questions sort of about, kids with transient high fevers, drowsiness when they're febrile, but sort of not, recovering after they've had sort of, Nurofen and Panadol, and what your approach is in that case.
So yeah, again, good question in that children do look pretty rubbish when they're febrile. And I always do reassure a parent about that too, because a kid is always happy and bouncy, and then they get sick and they just plummet like a lead ball. I always sort of say to the parent, and then I guess then GP, do the Panadol and Nurofen, watch and wait. And if there's good recovery, that's that's good. I think my concern really lies in between if they remain febrile and stay sort of drowsy and floppy, or if they remain drowsy and floppy despite having a normal fever. And also the other thing is remaining tachycardic without fever. So I would be quite concerned about a child who doesn't improve when you improve the fever, or if their heart rate doesn't improve when you improve the fever. Does that answer that question, I hope?
Yeah, I think so. I think the hard thing for us sometimes is that we don't have the luxury of observing kids because we
Absolutely.
only have 15 minutes. So sometimes
Yeah.
it's a bit hard, but I guess if you can adequately safety net, then that makes it easier for sensible parents.
Yeah.
There's
And
also
sorry, and
no,
we
you go.
do that, and we do that too, because you really do place a lot of trust in the parent. So if you just aren't certain that the parent is going to be able to access or is understanding, even with sort of written information, because I give a fact sheet to nearly every kid that comes through my door. I, you can send them in, or there are some other resources that I've got at the end of the talk that might also help.
Great. And you're happy with Nurofen and paracetamol for children if they need both of them? That's fine.
Absolutely. They're both very different medications. I often will like I think if the child's early in their febrile illness and they've got really high fevers, I will say to the parent, do one, wait 10 to 15 minutes, because the absorption is minutes with liquid paracetamol and ibuprofen. So I will often say just wait 5 to 10 minutes. If they're still looking pretty rubbish, give the other one. However, if they're sort of on day 2 to 3 of the illness, then I'll sort of start to talk about alternating so that you've got something to use every couple of hours through the day, and that can actually be quite useful. And not forgetting that if you've got the child that doesn't like syrups, that the suppositories are available and really useful for the little ones.
Great. And then just one more sort of two-part question about neonates. So for neonates still over 38, a fever, so between 37.5 and 37.8, between 37.5 and 38, would you consider that a fever even in a neonate?
Look, there are some differing guidelines between different institutions. A fever of 38 in the ED, no question. There are some greys depending on where you work. So I have seen 37.5 on guidelines before, but typically it has to be caught in the ED or a very convincing fever at home. Often if they say to us, oh, it was a forehead one, or one of those skin ones, we will just keep and observe the child for a time to see if we can catch the fever in ED. But if it's a proper sort of axilla one or 38 in the ED, that's no question. Yeah.
And axilla, if their parents are using a forehead thermometer or an ear thermometer, would that be low? Like, would you expect that to be lower than the axillary temperature or higher?
It's really so often I think it's higher. But I don't think you can say either or. So in the little ones, it's the axilla that you go for, and then I think it's over one or two, then the ear is acceptable. But you'll find, I think, that most of the people who come in, they've got like the sticky on ones, or they've got the little forehead ones, because I think they're kinder and they are easier to use, but a lot more inaccurate than the ones we'd use in ED.
Perfect. Thanks. Continue.
Thank you. So work of breathing. I can't stress enough how important it is to strip a baby and a young child to do an assessment. So I always tell my JMOs, an assessed baby is a naked baby. It's you can miss some really subtle but important signs if you don't strip a child. So with the work of breathing, I also put in poor feeding and irritability, because if a child is having trouble breathing, then they're not going to be suckling very well, or they're not going to be necessarily eating very well because they're working too hard to breathe. And it just might be something that it's just another question that I'll ask to sort of assess the global sort of work of breathing in a child or an infant. So just to remind you, the ones that are easy to see is the nasal flare, sometimes the head bob, but if they've got stuff around their neck, you may not see that. Um, Checking for that tracheal tug, the recession in the sort of at the clavicles between the ribs and under the ribs, looking for that paradoxical abdominal breathing in children or infants, tripoding in the older child, reduced interaction or flat affect, absence of crying, and that grunting sound where they're sort of basically activating their own auto peep because they're working so hard to breathe. Bronchiolitis, which we're seeing a huge amount of in recent months, mostly because of the big RSV outbreaks that we've been having, and flu a little bit earlier than that. This is the way I describe it to parents who come in is this is a disease of architecture. And it typically affects our little ones under the age of 12 months. Though it presents with wheeze, it is a different physiology to asthma. It's edema of the airways. It's not bronchospasm, and it really is that way I explain it is, they get a cold and if we get a cold, our airway is this big. And so when we get a cold and it gets swollen, our airways become this big. But when your child gets a cold, their airway goes from this big to this big. And so a lot of it is architecture and immaturity of the airways. Bronchiolitis peaks in its severity from around day 2 to 3, and then typically will start to get better after day 3, and it's almost invariably worse at night, like croup. All the breathing stuff gets worse at night. We don't typically do any investigations for these little ones. Swabs, chest x-ray, bloods, they don't need to be done. This is all symptomatic support and management. So in ED, all we're really doing is maintaining their hydration and their oxygenation. So room air to low flow nasal prongs to high flow nasal prongs to potentially CPAP is sort of the progress with these little ones. And then maintaining hydration, so regular little feeds, or if they need to move on from there, 2/3 maintenance IV fluids or NG feeds. Just whilst they sort of get through that kind of period where they're struggling to breathe. Other than antipyretics, so Panadol and Nurofen, we don't really use any medications. Superficial nasal suction, whether it be in the community or in hospital, can help, particularly if you do it just before a feed, but there's no indication for that deep suction anymore. It's more traumatic for the child, and it doesn't change the trajectory of the illness. Nasal saline drops prior to a feed. So I would often say, give a patient our little saline bottles, tell them they can put a couple of little drops at the nares, and then use the superficial nasal suction prior to a feed, and then they can do their regular little feeds through the day. With these little ones, obviously, if there's a moderate to severe work of breathing, send them in. Or if there's any other red flags, again, like the preemie child, or the failure to thrive child, the poor health literacy families, they can come in. But I would also consider sending in the child who looks sort of moderately unwell at day 1, because they're probably just going to get worse. So, because if I see a child on day 1 of their illness and they're just on the kind of cusp, I will usually admit them knowing that they're probably going to get worse, and I'd prefer them to deteriorate in hospital rather than at home. Because invariably the parent gets home and they're like, oh, I just went to the hospital, and they sent me home. I will admit those ones. Then we move into the grey viral-induced wheeze. So I think most people understand now that the puffers with a spacer is it's better than a nebulizer. It doesn't spread the antigen around. It delivers the medication exactly where it needs to go. There's fewer side effects, and just as efficacious as the nebulizer. We give steroids to the children who are moderately unwell with viral-induced wheeze, leaving the children who just have the mild exacerbations just to use salbutamol. There has been quite a bit of around overuse of steroid in breathing difficulties with children, particularly because you get the children that have multiple presentations and they just then end up getting lots and lots of steroid through, their early childhood years, and it's the damage that may do. So we're typically saving steroids for the moderate to severe viral-induced wheezes and asthma. Children under 12 months who have a wheeze are treated as bronchiolitis, not asthma, because bronchodilator treatment doesn't work. Remembering that viral-induced wheeze is typically precipitated by a viral illness, but if it's a sudden onset, then more likely to consider anaphylaxis, so treat it as such. So you'd be probably referring them into hospital if it's first episode. When these kids come into us, we treat them with a salbutamol burst plus or minus Atrovent. So this is 6 puffs of Ventolin via a spacer for under 6 years, or 12 puffs via a spacer for more than 6 years. So that could be done first in the community to see how they go with responding, and then send them into ED for their ongoing burst. An ED burst is those medications times 3 Q20 minutely, and then we sort of try and stretch them from there. But I think if you have a child who's got a moderate work of breathing with a viral-induced wheeze, treating them with an adequate dose of salbutamol is really useful, and then referring them into ED for ongoing observation and stretching of their Ventolin. Any child who is taking their Ventolin more than who are needing it, more than 3 hours. Yeah, so they're needing it before 3 hours. They should come into ED because they've got very little room to move if they're needing it more than every 3 hours. Like I said, there is a little bit of contention around steroid use. Most of the people, obviously, though, that I see in ED are moderate to severe, so I am using it. There are different protocols around at the moment, 1 milligram per kilo of prednisone versus 2. I think most of the inner city hospitals and children's hospitals are still using 2 milligrams per kilo of pred for 3 days, once a day for 3 days. And then children, like I said, less than 6 years. What's this? Children less than 6 years trialing. So basically little kids who have had their first presentation, we'll typically just trial them on salbutamol first. If they've just got a moderate, sorry, that should say a mild exacerbation. I'm sorry, that should say mild. It's my bad. Is there any questions around wheeze or anything before I?
Yeah, there's a couple. So one about bronchiolitis. So no puffers or steroids or anything like that are helpful?
No, nothing's been proven to be useful in bronchiolitis because it's just swelling of the airway.
And another interesting question actually about what age you think children can start using a puffer with a spacer, because sometimes they do not have the, I guess, ability to breathe in enough to make the valve move back and forth. Is there an age where you would think they wouldn't be able to use a spacer?
I think we try it on all the kids. I mean, I actually don't think I've seen, because normally I make them cry and they move that valve just fine. I mean, I don't think I've ever seen. I think certainly the kids that are really unwell and they're sort of really struggling to even sort of sit up, like, because we try and nurse all these kids seated up, like whether we prop them up with towels or so we can put them in that really good posture so that gravity is also helping them to breathe. And if the child's really unwell, then we use a neb, but typically all of them we're using a spacer and a puffer. And when it comes to taking them home, I teach the parent about lying the little one on the floor, putting the kid's head between their legs and holding their arms underneath mum or dad's legs, and then popping it on. And I think most toddlers even can manage that.
You're giving me flashbacks of my own children, Lisa.
Sorry, it's triggering, isn't it? I've always been
Um,
thankful my kids didn't have breathing problems.
And just a question about if a kid's had sort of 3 days of steroids and they're still wheezy, would you give them an extended course of steroids, or is there anything else you'd recommend?
No, look, I'd have them reviewed. There's no I don't think it's obvious that extending the steroid would actually improve anything. I think you need to sort of maybe consider a different diagnosis, whether it be foreign body, pneumonia. I think really having a review, maybe considering a chest X-ray at that point in time is probably prudent. I think prolonging steroid is going to possibly give you more problems, even though they might not be apparent. I would re-review and sort of reconsider the diagnosis at that point.
Perfect, thanks.
Okay. Croup, again, one of the ones that we mostly see at night. Again, 6 months to 6 years, so it does tend again to be a bit more of an architecture type of problem. I would refer in the children who have had previous severe croups. So these are kids that have needed multiple adrenalines for one presentation of croup, or have needed intubation because of their croup, or they have some kind of pre-existing airway problem like laryngomalacia, or the narrowing of the trachea, etc. Reduced airway tone, so like the laryngomalacia, or any neuromuscular conditions, or Down syndrome. If the child is very young, so under 6 months, consider an alternative diagnosis, and I would refer them in if they're stridulous under 6 months. Again, we don't do any investigations for these kids. It's a clinical diagnosis. They come in barking or stridulous. We minimise our handling and distress of the child. And if they're stridulous at rest, then we give them some DEX, and we give them, and if they've got a moderate work of breathing and stridor, then we will give them nebulized adrenaline. So the mild child who you see in your clinic with a barking cough alone and no history of stridor don't require steroids. They can just continue in the community with sort of antipyretics and safety netting. You can consider oral steroid if stridor is present, or there's other risk factors such as they're particularly young, or they've had other red flags or concerns in their development or medical background, or if they that they're not going to be able to access and urgent review promptly when they go home. But I would assume that everyone in the city can. Moderate croup will get steroid. Obviously in GP it'd be 1 milligram per kilo of pred. We do use DEX often in ED because it's one dose, and there is some evidence that it reduces the risk of representation, but the trajectory of the illness doesn't seem to change too much at 6, 12, 24 hours. And it tastes awful apparently. So it kind of depends on the clinician which one we use, but we do often use DEX in ED just because it is a one-off dose and we don't have to send them home with anything. Nebulized adrenaline for the child who's got worsening symptoms. So Actually, Claire, do you give Neb adrenaline in no, you just call an
No,
ambulance?
yeah, it probably wouldn't be something that a GP practice would do, particularly in the city.
Yeah. Yeah. No, I guess you can have an ambulance there pretty promptly and they can administer it and then deliver them to an ED. Any child who gets nebulized adrenaline is obliged to stay for at least 3 hours to make sure that they don't get worse again. And then any child actually who needs two adrenalines in the same illness, they get transferred to one of the kids' hospitals. So RPA, Canterbury, we typically won't keep a child who's needed more than or two or more adrenalines because there's just no room to move for us. So they will often get netzed out to a tertiary hospital. I would consider referring a child who presents late in the day and they're looking sort of tenuous, just because knowing that they may get worse in the evening, or tell the parent have a really low threshold to go into ED because this is it's possible that this will get worse as night kicks in. No croup questions?
Yeah, I've got a question actually.
Yep.
Is croup similar to bronchiolitis in that it gets worse on day 2 or 3? So if you see a kid and the parent said, "Oh, they were a bit barky last night," would you be inclined to then give them a script for some steroids because it might be worse because it'll be night 2, or is it just sort of seems like it's the same?
I haven't read that in the literature, that it gets worse on day 2 to 3. Really, this that it gets worse at night. So I think if the child in the morning is pretty barky, but is otherwise okay, writing a script for pred and saying, if they seem to be getting worse tonight, give this, and have it ready to go is fine. And then monitor for, an hour or so, or just go into ED. Because I think I kind of think it's better to be safe than sorry. But yeah, I don't think it's got the same 2 to 3 day thing as bronch.
Yeah. And then with a course of steroids for croup, is it generally 3 nights? 2 nights? Does it
3.
make a big difference? 3.
Yeah. Yeah. So Dex, it's once. Pred, it's 3. Once daily, 3 days.
Perfect. Thank you.
Okay. Gastro. There's been so much of this too, my goodness. So thinking about, I guess, when to send a kid in. I mean, I often do, and Claire's heard me moan about gastros that get sent into ED because I'd much rather be sick in my own toilet than a public ED toilet. But certainly there are times where you would want to refer someone in. So a child with red flag features. So again, these are the children who might have really high fevers, developmental or comorbidities, really young. I can't see my notes, so I can't see what I've written in my red flags, but I think I can go back and have a look at them anyway. But any concern in their background, you would consider a red flag, or if they've had weight loss, they're drowsy, of course, they should come in. A child who's vomiting without diarrhea, absolutely consider an alternative diagnosis. I think gastro is almost always textbook, where you'll have vomiting for the first 12 to 24 hours and then fairly promptly followed by some loose stool. You might have a little bit of generalized abdominal pain, and maybe a low-grade fever. I think the other thing that I worry about is that if they have severe, or they have abdominal pain and then the vomit, that always makes me a little bit more suspicious that maybe there's something else going on, and I'll have a lower threshold to do bloods on those kids. And obviously if they've got focal discomfort rather than generalized discomfort, I'll be investigating further on those children. Most of these children don't need investigations, including stool tests. I'm not typically getting poo from any of these kids. I'm just we're doing. Well, I think I go through what it is that we do with these kids, but wherever it's possible, doing the oral route of fluids oral rehydration is much more effective and efficient than doing it via IV. So most of these kids really can be supported in the community with the right instructions on how to keep them hydrated with oral fluid. We absolutely use ondansetron in these kids, and I can't see why it wouldn't be safe to do so in the community. So any child over 6 months, we do give ondansetron to, and then do the trial of fluid. So 8 to 15 kilos, we're giving 2 milligrams, 15 to 30 kilos, we're giving 4 milligrams, and then over 30 kilos, again, I'd probably typically just do the 4 milligrams, but then I've got some room to move if they've failed trial of fluids. But look, if they've failed trial of fluids, they're typically going to be coming into short stay or something, or getting a short admission for ongoing observation and hydration. So the trial of fluids that we do in ED is that we aim for 10 ml per kilo per hour of oral hydration. We always try and offer something like Hydrolyte because it's just much more efficient. Though if the child doesn't like the oral rehydration fluid, we can give them diluted apple juice 1-to-1, which has been shown to be quite efficacious. I guess it's just not good to have that alone because it doesn't have the electrolytes in it. But if it's the only way that you're going to get fluid into a child, 1-to-1 apple juice is quite palatable, has a little bit of sugar, and is an adequate hydration fluid, just not sort of long term. So trying to get other things like salty broths or something into them is also a good option. If the child's breastfed, then you just continue breastfeeding, but more often, and you can give them oral rehydration fluids to supplement to maintain hydration, and aiming for those 4 wet nappies a day. Once they're rehydrated, recommencing a normal diet. I will often just say small amounts regularly, avoiding anything too fatty, and if they're an older child, too spicy. Temporary lactose restriction isn't necessarily required unless the parent is finding that it is increasing the diarrhea. Usually the thing that increases the diarrhea is that they're having a large bolus of food or fluid, and it's just sort of triggering that orogastric reflex. But it's often not the lactose. Something else I was going to say about reintroducing fluid. So little bits regularly might come to me. Yeah, I think that was all. There's something I've lost it though. I'm sorry about that. Oh, I've got this as a little outline just so that you're aware of what we use to sort of follow what we use in ED to sort of it can be quite difficult to get a parent to commit to this. We love the parent that every 5 minutes they are just pumping in this like little 5 mils of fluid to their child. But this is basically what a parent has to fulfill with their kid over the space of an hour, usually after some ondansetron, to pass a trial of fluid. And then if they appear to have improved, we've gotten some urine, they've had no further vomits, they've just had maybe some diarrhea, that's fine. And then with discussion with the parent, we talk about getting them home. My favourite fact sheet for gastroenteritis is the one from the Sydney Children's Hospital Network, because it has a really clear fluid guideline for the parents. So it sort of outlines that they should be having at least 5 mils of fluid per kilo of body weight per hour. So it's a bit less than what the trial of fluid is for us in ED. And then, per their weight, it'll just give them sort of an idea, a ballpark of what sort of fluid intake they're aiming for. And then I always sort of say, then you're aiming for at least 4 wheeze a day and a reasonable constitution, that they're sort of, alert, all that kind of thing. Oh, that's what I was going to say. With lactose, and anything that the child will eat is great. Yogurt's great because it's going to start replacing their their good bacteria. So I basically say to the parent, whatever they'll take, let their palate guide them. Give them what they really want. Just give them small amounts regularly rather than sort of big lots, because it'll just sort of trigger the diarrhea. So lots of sips regularly. I think that's all about the gastro. Is there any questions there?
Yeah, just a couple. Do you guys in ED give children ondansetron to take home if after they've passed a trial of fluid? Just because ondansetron is actually quite expensive to buy in the community from the pharmacy because it's not covered by the PBS. So, yeah, do you guys give them ondansetron to take home for a couple of doses if they've
Yeah, I do. I mean, I always do it with the if everything persists, low threshold to come back. But I will give 1 or 2 tablets to a parent to sort of say, because the way I will preface it is you expect to have vomiting for about 24 hours, followed by an invariable number of days of diarrhea. So if we can just get you through that 24 hours, then hopefully the vomiting will stop. You'll be able to keep up an adequate oral intake, and then the diarrhea will just sort of happen and clear over days. So I will send some kids home with a tablet or 2.
Yeah, and you can definitely cut the wafers in half or the tablets in half.
Absolutely. They're teeny tiny, but yeah, you can.
And another question actually is quite interesting about kids that are coming with like vomiting and diarrhea, I guess. Are they getting sugars done in ED? And should we do that?
Absolutely, which is my next this one. So Claire knows this is so close to my heart. My middle boy, my middle child has type 1 diabetes, and I guess being in that world, you meet so many kids that have had late diagnoses of type 1, children that have been diagnosed on formal bloods, and then fall unconscious in the car after the pathology's called them to send them into ED. So absolutely, we do check sugars and ketones on. They should be checked at triage or just after hitting triage if they come in with diarrhea and vomiting. I absolutely want to know that they're not hypoglycemic because of poor oral intake, or if they're ketotic because they've had poor, they've got starvation ketosis. Alternatively, if a child has abdominal pain, vomiting, or lethargy, I'm getting a sugar because it's so easy to diagnose very, very promptly. And if not a finger or a toe prick or a heel prick on a child, check the urine if you can, because glucose is present in the urine at a BSL of 10, and 11 is a diagnosis of more than 11 is a diagnosis of type 1. So I implore people to not forget to do a sugar on kids who come in with sort of gastro symptoms, abdominal pain, unexplained weight loss that because it's not always due to a growth spurt, unexplained lethargy, the big increased respirate when there's no other respiratory symptoms or clear chest, dehydration despite drinking, or new bedwetting. Just to remind everyone, it is the fastest growing chronic condition in Australia. 10% of all diabetics are type 1, and it's growing. 130,000 people live with type 1, and there's 8 new patients a day being diagnosed. So it's not uncommon, and certainly anecdotally from the kids' hospital that we go to regularly after COVID and flu spikes, they definitely see a spike in new diagnoses. So it's been a big couple of years for the diabetic services. Oh, Lydia's got her hand up.
No, my apologies, mistake. Okay. But we do have a one of the attendees raising their hand. Now I wonder if they would like to ask the question. I'll text them in the meantime and get back to you on that. Thank you.
Were there any other questions, Claire, before I move on to abdominal pain?
No, I think
No.
you
Okay.
can move on. Yep.
Cool. I was asked to sort of touch on some surgical types of presentations. I'm not going to do a huge amount, but I hope that I'll just make it a little bit practical from a GP perspective, I hope. It's abdo pain is really hard, and in ED we are also often scratching our heads a little bit, and really we've got that the privilege of sort of the watch and wait in ED, which I know you don't. But I guess the things to always kind of have at the back of your mind is um, looking at the general constitution of the child, always remembering that a full abdominal assessment on a boy child is to do a testicular exam as well, knowing that sort of testicular torsion has a few peaks, neonate and then adolescent, and then I think um, young adult. So there's a few peaks to sort of think about. Um, it it is really tricky. I think the things that we definitely want to see in ED are any child who's got abdominal pain secondary to trauma. I hope that you're not seeing too many of them, because I guess if through a GP surgery, it would be likely from a playground fall or from non-accidental injury. Any child who's got that focal tenderness, and you're querying something like appendicitis. Um, Foreign body ingestion. And so I think the thing with foreign body is any button battery or anything that's like 5 centimeters long or more than 2 centimeters wide or particularly sharp. They're the things that sort of need a prompt trip to ED. Interception, so that's that colicky child who has those extreme but usually brief periods of pain. They usually crouch down on the floor or pull their legs up if they're particularly little, and then they're kind of right as rain and seem to recover. The child who's got the bilious vomiting, ovarian torsion, tricky, but I guess that's that sudden left or right sided pain, and it's often associated with vomiting. It's kind of like testicular torsion can be too. I often say to my JMOs, when something's trying to die inside you, you vomit, and your lactate goes up. So if you're sort of seeing these, and that's why I sort of said before, if it's vomiting but no diarrhea, um, then you sort of have to have these other sort of thoughts in your mind. Incarcerated hernia, if there's been any toxin ingestion, and then any child um, who has menses, who menstruates, just also think of ectopic, but hopefully not. I just put this in, I guess, for reference of, the different parts of the abdomen and what you're sort of thinking about. But I think if the pain is severe, um, and they look unwell, just send them in, because like I said, often with these kids, we just will watch and wait unless something is quite obvious. I hoped that this might be practical. So having worked with Concord, RPA and Canterbury, I've also sort of worked up at Hornsby and obviously out at Westmead, etc. Most hospitals will only have ultrasound 8 till 4 p.m. Monday to Friday. We don't have access unless there are some, like Canterbury doesn't, but I think Concord and RPA, if a testicular torsion comes in the middle of the night, there is a sonographer that we can call in emergently. Canterbury does not. But if you're after an ultrasound, it's only very specific times, and sometimes the sonographer that we have isn't particularly confident in ultrasounding children. So it's just to know that. And I just wanted to go over the admission policy at RPA too for surgical patients. So RPA is quite tricky. It's not necessarily the surgeons that have the issue with admitting. It's that the anaesthetics cover as well isn't necessary anaesthetic. This isn't pediatric comfortable. So the children that we keep at RPA, so for orthopedics, they will consider keeping over 2. So certainly for a conservative managed fracture, they'll keep. For an ORIF, they technically can keep over 2. Sometimes they'll move them out. ENT 2 and over, gynecology 14 and over, colorectal and upper GI 12 and over. So you can see that that's quite tricky if you've got a child who you think has appendicitis. Urology 8 and over, plastics 12 and over, neurosurge 16 and over. And I can't see my other one because it's over it. Hang on, I'll just try and move my. And ophthalmology, there you go, any age, they keep any age. That is fairly Concord won't see any kids, so they'd send all of theirs to either Canterbury or RPA or the Children's Hospital, and then Canterbury is fairly similar to this. Was there any questions about the surgical stuff?
There is not. There's just a couple of questions just left over from before, which I think I'll probably just ask now. Loperamide. Do you ever give loperamide for diarrhea, gastrostop?
Never.
And what about abdominal X-rays in children with sort of abdominal pain that maybe is, coming and going? Do you think they're useful?
Not really. Oh, did I stop sharing my screen? I can't see my screen anymore.
Oh, we can still see it.
I can't see my slides. Don't know how to get it back. Sorry. I can't get it back. Okay, I'll have to figure that out in a minute. The abdominal X-rays. The literature says no. I obviously do it if I'm concerned about obstruction, and we do it for a foreign body or query foreign body ingestion. When it comes to any other form of abdominal pain, you shouldn't. But I'm not going to say it doesn't happen. Certainly for the child who has constipation and you want to see how much poo is there, that still does happen. But I think if you've got a soft, non-tender belly and a history of a child that isn't opening their bowels or has something consistent with overflow, it's not really going to change how you treat the child. So typically, no, there's only really the obstruction and the foreign body as the indication for the abdo X-ray. Ultrasound, however, very different story.
Mm-hmm. And are there any, just in terms of loperamide, are there risks with loperamide, or it's just that it's not that helpful with gastro?
I think the risk of causing like things like toxic megacolon and things like that, you don't want to arrest the bowel when you have a diarrheal illness. And I think that as well with adults. I don't typically get people to stop unless they're traveling or something and they sort of have to, they don't have access to a toilet. If the child has an infective diarrhea, it just needs to pass and you need to let the bowel rest by having small oral intake regularly and not take big boluses that'll just sort of move the bowel quickly and often. I just think there is risks and it probably prolongs the illness if you give it.
Perfect. Thanks.
It's okay. Now I've got to try and figure out how to get my screen back. I might just stop share, sorry, and then I'll do it again and maybe it'll come back. There it is. Yeah, there, great. Okay, I wanted to touch on mental health just because I don't know how clear it is in the community what we can do for children. I think mental health is a really difficult problem for the community and the hospital. There's just not enough mental health support or facilities. I just wanted to clarify that none of the hospitals in the Inner West are paediatric mental health facilities. So if you send a child in crisis to RPA, it's difficult for them to manage. If a child is under 16, they will get admitted by PEDS, but they will try and get them transferred as quickly as possible. They really don't like mental health patients on the general PEDS ward. So they'll often end up just staying in ED. And over 16, then that again is quite tricky, particularly if they're still at school, because you've got that issue of sort of still being a minor versus emancipated minor, an adult. So it's tricky. So if you can refer them to the children's hospital, that is ideal because they do have better facilities and support. In saying that, if there's a mild to moderate mental health condition that you think can be managed in the community, then there are nurse practitioners at each of these hospitals who are excellent. So RPA typically have more hours covered. So I think they'll have a nurse practitioner on from morning until sort of about 6 in the evening. Canterbury has just one single nurse practitioner. She's Monday to Friday. Typically takes her last patient at around 4 o'clock. Um, Canterbury also has a really well-established domestic violence and child protection CNC, who's readily available to see patients during the week as well. And Concord, like I said, they don't really see children. But when I spoke to the CNC there, she said if the patient is known to their service, then they would consider seeing them and if they could admit them there. But they typically have to be quite a mature child who's already known to their service. So I just wanted to go over some of the services that I thought might be useful just to sort of know about in the community. And I wasn't sure if these were part of those health pathways, Claire, that you mentioned before. But RPA Virtual has an acute respiratory clinic. So this offers respiratory monitoring. So you'll get virtual nursing, medical and allied health care for patients who have a mild to moderate respiratory illness that you may have otherwise considered to go into hospital for admission rather than being treated at home. But they need to have sort of regular close monitoring. Diagnoses that you can consider in a child or an adult is community-acquired pneumonia, COVID, influenza or other viral illness, a mild to moderate exacerbation of COPD or asthma, exacerbation of other chronic lung diseases like bronchiectasis, and if you've just got any concern that they might deteriorate. So ED, we can refer from age of 16, but apparently from the community, you can refer any age. What the patient can expect is basically safety netting. They'll receive a pulse oximeter delivered to their home, a thermometer. They will have regular contact from the nurses who will do contact. So they do need to have access to a smartphone or a computer where they can receive sort of a FaceTime. They have access to RPA Virtual 24/7 by calling a central line, and there is a multidisciplinary team that is in the hospital. So psych, social work, etc., and interpreter services. My computer might be dying. I wanted to mention the RPA Virtual Fracture Clinic because I think this is a really great resource. I'm just going to get up and move and talk. So I think particularly for peds, if you end up diagnosing a forearm buccal fracture, these are the kids that are really going to benefit from referral to the RPA Virtual Clinic. So just to go over buccal fractures, this is what a buccal fracture looks like on X-ray, so it's buckling of one or more of the cortices of the bone as a result of a compressive force, so a foosh. It's typically a fall from standing onto an outstretched hand, and they typically occur in children younger than 10 years of age, and it can involve the distal radius and or ulna, and it's the distal part. So if there's if the pathology is in the middle or the proximal part of the arm, that is not a buccal fracture. And if there's any breach in the cortex, that is not a buccal fracture. Buccal fractures require splinting for 3 to 4 weeks unless you think the child's not going to be compliant. Otherwise, the children that you aren't going to splint are the children that even though it might not be obvious on the X-ray, but the child is really quite distressed with pain, I just send them into ED because typically they'll end up needing a plaster, and then it might be a plaster for a week and then a re-review just to see if the pain has settled down, if it's not obvious on the initial X-ray. A green stick fracture, you wouldn't put in a wrist splint. They need to be in a plaster. If there's any significant angulation, so of more than 15 degrees, they will need to have a plaster. If there is suspicion of or actual fracture extension involving the growth plate, then they need to have a plaster. If there's a second fracture, obviously they'll need to be put into plaster. If there's scaphoid pain or if there's significant pain or swelling, they should probably get more orthopedic specialist review and follow up. They've also got RPA Virtual also has an urgent care service. So this is more or less like calling an admitting officer of your local ED. You'll get onto a FACEM who you can talk about the case with, and they can help you either refer through to any one of the clinics that they think are appropriate, or they may suggest actually, just get them to an ED for further review if there's any concern. I did see Claire put that virtual kids was in some of the slides. I think that Claire and Lydia put up at the beginning of the talk. I've done quite a few chats with this crew, and it does sound like an excellent service. It's one that we are referring to directly from paramedics as well. So New South Wales Virtual Kids is also doing sort of FaceTime assessments of children. And I think these guys are really useful in checking those kids to see whether or not they're passing a trial of fluids, to see if they're improving, or to see if their work of breathing is deteriorating. If the parent and child want to access it once they get home, they just have to call Health Direct and they'll get put through to the Virtual Kids service if it's deemed appropriate. I think that any practitioner can also refer directly. Certainly, paramedics and paramedics are. So I think there is the number that you can call them directly and get through to the nurse and then onto the peds, the peds/ED fellow from there. They will commonly see babies and children with the respiratory illness, fever, vomiting, diarrhea, rash, decreased fluid intake, and generally feeling unwell. And like I said, they may just restart like a trial of fluids and monitoring. But I think the beauty of seeing the GP first is that you can take a set of OBS and have that for the virtual kids doctor, and they find that really useful, particularly if there's a sugar and a heart rate, and they can then do a sort of fluid status and ongoing review of the child, and then decide after however many hours if they can stay at home or come into an emergency department. I wanted to just go over, I guess, the things that we use most regularly in ED as our resources. We constantly go back to the clinical practice guidelines of Royal Children's Hospital, ECI, and the Sydney Children's Network. The Royal Children's probably has the best clinical practice guidelines. The fact sheets from both child networks are excellent, and ECI also do really great fact sheets and asthma care plans and all of those. And obviously the therapeutic guidelines for sort of the most up-to-date antibiotic stewardship and I guess community care of almost every presentation. This was to remind me to talk about the fact sheets from ECI and the Sydney Children's. And also don't forget your local admitting officer. I know I can only speak for myself and most of my colleagues, but I never begrudge a GP calling through on a shift to give a brief handover or ask a question to sort of determine whether or not a patient is appropriate for ED, or just to give us the heads up that someone is coming. I think we can't work in a silo. Phoning a friend is always useful, and sort of sharing risk or sharing a decision is a really useful thing. So call through, switch, ask for the admitting officer if you just think you need to clarify what's happening in front of you. I think that was it.
Excellent. Thank you so much, Lisa. There are a few leftover questions, and we've got about, 10 minutes or so. Mm-hmm. So I might just go through some of them quickly. There's a couple about fever, and if you could just clarify in terms of, so if we see a, baby in our rooms and we've got a ear thermometer and the temperature's 38, that classifies as a fever for us? Yep. Perfect. Yep. I think most GPs probably have ear thermometers or forehead thermometers. I don't think we're doing many auxiliary temperatures in general practice, but maybe.
Look, I think if a doctor measures 38, we'll just call it 38. I mean, I think the thing is that, if it's a parent, and it can be a bit more subjective when it's at home, and yeah, I think if you've assessed it, they're a febrile child, and particularly if they're little, it's fine.
Perfect. All right. There's a question about, if you say you send a child to ED, they get sent home, then they represent to you and they're still looking unwell. I presume the answer is just send them back if you're still worried that they're unwell and they've been sent home from ED once.
Oh, absolutely. I think represents, look, we always take represents really seriously, or I do. I think sorry, I'm going to sneeze. I think if there's parental concern and the child isn't going on the trajectory that you have thought that they were going to take, then you just send them back in. I never want a parent to feel like they're not welcome back. Sorry. Pardon me. Which is why I will always say to a parent, if there is any concern, it's never silly to come back, because I can only sort of tell you what I think will happen. And if that doesn't happen, then, you come back. You're the child's biggest advocate and you know what's normal and what's not. So absolutely come back.
Perfect. And kids with gastro who aren't tolerating oral fluids by mouth, are they getting NG tubes in ED, or do they get IVs?
The little ones do. I mean, the guidelines say NG first and foremost if they're not vomiting. Also note that you can give rapid rehydration via an NG, but I think practically little children tolerate this better. Once they're bigger, they don't really tolerate the insertion of the NG, and they'll often pull it out. So the little ones, we do an NG on, and that would be our sort of first line. Once they're a little bit older, then we are doing IV.
Just a practical question about RPA virtual. Do you know how long it takes for them to contact the patient?
Oh, so they do it within the day, usually, so yeah, it's within the day. So when we refer people over, you should get a call from an RN before the end of the business day even on the weekends, to basically do the intake call and figure out what the sort of care plan should be from there and who should be following up. And then once that intake call happens, then it gets escalated to whichever CNC or doctor needs to take over from there. And then an RN should be calling several times a day to get some OBS and just to check in. And then I think if it's a CNC or a doctor that needs to review, then that may be once to twice a day, depending on the severity of the illness. And then they will refer to ED if they're just not managing in the community. So we get, several referrals now in ED that have come from RPA virtual.
And GPs can refer to RPA virtual?
That's what, because I did speak to my colleagues there. It's absolutely, so there is an intake. So the number that I put on the slide, the one that should be direct. There is a FACEM that you can speak to confirm that the referral is appropriate, that they can take it, and that they would suggest to you which service would be best, and that they can actually arrange in that phone call the referral to the service that is appropriate for the person. So this is children and adults. I was absolutely told by the FACEM there that they should be able to see under 16s. I think there's going to be a little bit of crossover between Sydney Virtual Kids and RPA Virtual, but I was advised that from GPs they'd accept any age group.
And it's different to HIF, to hospital
Oh,
in the home?
absolutely.
Yeah.
Absolutely. So RPA Virtual now looks after community nursing in the SLHD, but HIF again is different. So HIF is its separate service. You actually have to go in to HIF to access it, whereas community nursing goes to you. And the other thing that HIF has is eHIF, which is the emergency HIF service. So that's elderly people in their home that may have had a fall, or maybe they've got a UTI or things like that, and that an eHIF can actually send out more or less like a flying squad to the patient in their home and do an assessment.
Yeah. Great. I'm just having a look. Oh, there's one about kids, babies who have had Bexsero or any immunizations, I guess, and then get fever. So, like, say after 6-week immunizations, baby gets a fever after that. What's sort of your approach to that if they're presenting to you guys?
It's still the same. It's still symptomatic management. It's looking for the focus, and for me, it's still going to be a diagnosis of exclusion. I would only really expect probably a low-grade fever from an immunization, and I would really be doing symptomatic management and seeking the focus, and sort of just keeping them for a few hours just to see which way they go. And I know that's really hard for you guys, but I think, again, if you're giving an antipyretic, they perk up, they're otherwise pretty well, then they're probably okay. But if they seem to deteriorate and they've got a high-grade fever and no other obvious focus, then I'd just sort of suggest that they come in for review.
Great. And there's just a couple of questions about diluted apple juice for oral rehydration. Do you guys dilute it 1-to-1 or
I've seen
1-to-4 or 1-to-3?
So there was, when I read that out, I was like, oh. So there's two guidelines I've read. One was 1-to-1 and one was 1-to-4. So I think that's the more dilute, the better, really. And it also, I guess, depends on what sort of apple juice you're using. But yeah, I'd probably err on the more dilute than So 1 to 4 is probably better, or 1 to 3. I mean, if it gets too dilute, the kid's probably not going to drink it. You're just
It's
trying
just
to get
water
fluid
then.
into them.
Great. And his lemonade, okay, diluted lemonade. Is that all right?
They do say you can, again, I do 1 to 4 for dilute. And actually on that Sydney Kids Children's Network, they have that list of appropriate oral hydration fluids, and dilute lemonade and dilute apple juice is on there, and it has the preparation written. So I find that so useful. Here, take this, put it on the fridge, and it's also got the little list of, and this is when you should take to ED. I love those fact sheets because I just think you just have no bandwidth at all when you've got a sick kid. Just need a
Great.
visual prompt.
Yeah. So I think we're right on 8:30, and we've come to the end of all our questions. So I just wanted to say thank you so much for presenting. It was really helpful, really useful. I think everyone would have got a lot of good tips out of that
Thank you.
presentation.